Thanks very much for inviting me to a surgical audit meeting. So I'm a intensivist and an anaesthetist, and I practice 4 weeks in each, so ICU and anaesthetics. And obviously elderly surgical patients, elderly patients in general, is a significant problem that we all face. And ICU, is certainly no exception to anything else. I was just going to take a slightly different tact initially and just really talk about, life expectancy and kind of the size of the problem that we have, a bit of epidemiology. So life expectancy is kind of defined as the average number of years left at a certain age. And so we define life expectancy, so at birth. So someone who was born in 2014 and who was a male, in Queensland, you'd expect them to live to 79.9. And the national average is about 80. And in females, it's slightly more, as we all know. And this graph is from the Bureau of Statistics in 2014, which just shows that, there's a continuous upward trend of life expectancy, as we all kind of know. Australia is about 6th in terms of OECD countries, and the USA is slightly behind us, just as a comparison in terms of average life expectancy. I've often heard, particularly in the media, the quotes that, there's a person born today who's going to live to their 150, and although we're all getting older, that whole age is shifting up a bracket. But it's probably not true. There was a reasonably recent article in Nature, actually, this year, which just looked at actual maximum lifespans, and humans are probably capped. There's been very little improvement in terms of maximum life expectancy over the last 30 or 40 years. And this is just a graph that kind of demonstrates that. So if you look at the oldest person who dies every year, from about 1990 on, there's just a flat line. So there's a couple of outliers. So this lady who's the oldest human being that's been documented died. She was a French lady who died at 122, so she's extreme. And there's a Japanese man who died at 119 years old. But the rest, the maximum average age of death for most countries is kind of around 110, 112. And this other graph looks at rate of change since, for the last 110 or 120 years. So we've made some progress. There are more younger people who are surviving a little bit longer. We've stopped some of the kind of early deaths. But the biggest round of change has been this kind of 70 to 90, 70 to 100-year-olds, where there are a lot more people who are entering those age groups, but really beyond 100, there are very few people who still survive beyond 100. And that is most likely, almost definitely, because we are very good at specific disease treatments. We have substantially decreased risk of cardiovascular disease. We have a lot of improvement in nutrition and safety in terms of motor vehicles and smoking in certainly developed countries, and a whole lot of life-saving disease-specific modalities. But there's been almost no really treatment or advancement to treat the normal aging process. And so what we're doing is stopping early death. So the people who are going to die in 50s, 60s, 70s, they're no longer dying. They're living older, and so that's where our ageing population, our life expectancy mean is increasing, but actually there's probably a cap on how old they are, and probably 100 to 110 is the limit of what the kind of human biological ageing process can get to. So, and this is just a graph from the American data about their all-cause mortality. So people are getting older because we're stopping that early death. There's less percentage of people dying every year than there ever used to be. And obviously that means an ageing population. So there's an increasing number of that kind of average age group. There's more number of people in those kind of older age groups. And it's estimated in Australia by 2050, there will be, a quarter of the population will be older than 65 years of old. And that's a global phenomenon, as that kind of graph demonstrates as well. And ICU, just like hospital admissions and in general, has a much greater increase in the admissions of elderly patients. And we see nationally about a 5 or 6% increase in patients who are older than 80 years age over the last kind of 5 to 10 years. The normal physiological process of changing we really haven't addressed at all. We're very good at disease-specific modification, but there hasn't been any really advancement on normal physiology of ageing. And obviously ageing is a complex process that has both genetic and environmental contributions. But a normal process of ageing is a normal decline in every organ system function. as well as a reduction in the amount of reserve it has if it's stressed, and that's irrespective of the organs, respiratory, cardiovascular, and neurological system. And so obviously physical performance is decreased, so you get disruption of the physiological system, circadian rhythm, endocrine function. There's obviously a loss of complexity of physiological ability and disordered homeostasis, particularly in the face of significant physiological stresses. And I would say, certainly I've heard it once already from Craig's talk about a good 93-year-old. I mean, I don't think that exists. There are elderly people who have significantly severe comorbidities, who we call kind of bad 92-year-olds, and then there are elderly people who have no medical comorbidities, and yes, they may be physically fit, but that doesn't alter their ability to mount a physiological response in the face of significant physiological derangements. So I think, you know, an 85-year-old may be functioning fantastically well with no physiological response, but if they get critically unwell, they're never going to have the physiological reserve of a 45 or 50-year-old, regardless of what their level of function was prior to that initial illness. Just looking at kind of ICU data, it's kind of elderly is no universal definition. Certainly in the ICU literature, people use a definition of greater than 65, greater than 75, greater than 80, and now kind of some studies looking at kind of the very old and kind of greater than 85 years. Just one kind of paper just about anaesthesia outcomes in the elderly. This was an Australian paper, and I'm sure most people are kind of aware of it. The Reason study, which was published in 2010, but run in 2007 and 2008. And this looked at 23 major hospitals in Australia and New Zealand, every sequential patient who was non-cardiac surgical over the age of 70 who was going to be admitted for more than 24 hours, expected to stay more than 24 hours. And it got huge numbers, so 4,100 patients. And purely being older than 70 who had an operation, you had a 30-day mortality of 5%, which is not insignificant when you're looking at kind of certain outcomes. 10% went to ICU. Of that, about 5% that were planned had that same kind of mortality rate. Of the 4.5% who didn't have the mortality rate, so someone who had an unplanned admission to ICU, 1 in 5 of those patients died. And as you can see there, the complication rate, at least one complication in the first 5 postoperative days was also significant. 1 in 5 patients had a complication, and of the patients who developed a complication, 14% died. And one of the substantial things was the correlation with mortality was not really related to the surgery that was performed. The correlation was the patient factors, so increasing age, ASA kind of comorbidities, and obviously emergency surgery. So looking at ICU outcomes, unsurprisingly to certainly most people I'm sure, elderly patients who are significantly deranged in ICU do quite badly. So one of the large Australian retrospective audit from all Victorian ICU, so every Victorian ICU in that 12-year range, they looked at patients older than 65 and they had huge numbers, 110,000 patients were admitted, and their ICU mortality was 16%. And if you looked at the older age groups, so greater than 80, they had a 25% mortality. And that's compared to a younger age cohort of only about 8% of patients who are less than 65. Another Australian trial, which was an ANZICS database, so every ICU, most ICUs in the country submit data about admission variables, age of patients, diagnoses to a ANZICS core database. So it's an excellent repository of information. And in the 5 years, 2000 to 2005, again with that patient population greater than 80, again it had about a 12% ICU mortality and a 24% hospital mortality. And again, this is reflected in a single centre study that was produced this year from a tertiary hospital in Canberra. Again, they looked at hospital mortality, and they also looked at that kind of 12-month mortality, because obviously 10 or 15% ICU mortality is a very short term. And likewise, not only do we really want to know about mortality, but certainly the more important issue, which was kind of discussed previously, is what they're like morbidity-wise, and more beyond just the ICU and the hospital stay, what are they like? And this is a very large, probably the largest prospective ICU trial from the Canadian trial group, which have a similar hospital admission rate to Australia. And they looked at 22 tertiary ICUs in Canada, and patients greater than 80, and they had about 800 patients who they identified, and they had patients who admitted for more than 24 hours into ICU, and again a very similar mortality to 14% ICU mortality, again a 26% hospital mortality, but they also prospectively followed them up for 12 months, and they have 44% 12-month mortality. So if you come to ICU and you're older than 80 and you stay more than 24 hours, which would indicate probably not just a post-operative monitoring, then you've got a 50% chance of being alive in 12 months' time. And of those survivors, only a quarter of those survivors, so 1 in 8 people who actually came to ICU were at their baseline functional state at 12 months. Now, I'm not sure that really anyone is aware of the significant impact really down the track and as part of the discussion that that's had. That is replicated, I won't go all through those trials, numerous times through all the countries. So there's French trials, there's US data, there is Norwegian and Danish data that suggest a very similar trend with about a 10 or 20% ICU mortality, about a 30% hospital mortality, and somewhere 50 to 60% 12-month mortality. Again, we're trying to look at predictors of mortality. Is it just age? And there's been a number of work done to looking at who are going to, contributing to that ICU mortality. And certainly, increasing age has been associated as an independent predictor of death from that ICU. It increases 2 to 3-fold for every decade of life greater than 70. So an 80-year-old has 2 or 3 times the risk of dying coming to ICU than a 70-year-old. Frailty is also certainly a marker of decreased functional physiological reserve, and there's a number of physiological scales that are looked at frailty, and increasing frailty also is a predictor of mortality in ICU, as well as disease severity. So someone who comes with a significant physiological derangement has less reserve and certainly increased risk of death. The financial cost was the other thing, kind of an ICU. We are the expensive care unit. Everything we do costs a lot of money. The US data is astounding. So in 2009, 17% of their GDP was spent on healthcare. That is $2.5 trillion, and 60% of that was spent in the last 3 months of patients' lives. And obviously that's not all ICU, that is 3rd, 4th line palliative chemotherapy agents, obviously prohibitively expensive, that's surgery, that's hospital admissions, that's a whole lot of last-ditch kind of effort, and really the question is whether that enormous financial burden is actually worth the cost that it has. One of the other astounding things in the US is that out of everyone who dies there, 30% of patients who die have spent a time in ICU in the last month before they died. That comes, part of the problem with the US is they have this thing, demand elasticity. So the US has 25 ICU beds per 100,000 population, and there's been some comparative articles looking at the UK, which has 5 ICU beds per 100,000 population. So there has been no appreciable difference in outcomes between the US and UK ICU outcomes, kind of a number of disease states. Australia is somewhere in between, more close to the UK kind of model, but certainly you would argue that Australia is doing more and more with their expansions and kind of who we admit. And part of demand elasticity is kind of that graph on the side. So our target population ICU should be someone who's very sick, who should have a chance to survive, who we can make a difference in. If you're very sick but have no chance of survival, or if you're going to survive because you're not very sick, that would be, arguably wasted resources, particularly this cohort here, particularly in the elderly. So the people who've got, significant disease burden, either acutely or chronically, expending, time in ICU and intensive treatment, how much benefit that has with very limited risk or chance of survival. So Australian data, again, this is from the ANZIC's core database. In Queensland, we have 391 ICU beds. And Australia, about 2,300. Our overall mortality in Australia is similar to kind of other data, about 7.8%, probably about less than the US has about a 15% mortality. Of our electives, of our total admissions to ICUs in Australia, 30 to 40% are elective surgical. Now, a lot of that data is actually cardiac surgical, so some cabbages and valves, but there's obviously a substantial amount that is non-cardiac. And again, the top 5 diagnoses of admission to ICU, 4 out of those 5 are surgical diagnoses. So we see a lot of surgical problems. The cost of admitting futile people to ICU is not only a cost to the patient, but also a cost in resources as well as an opportunity lost cost. And particularly for surgeons, that opportunity lost is elective surgical admissions that can't come to ICU because there's no resource availability. And again, looking at this data in a lot of the tertiary hospitals, about 3 to 4% of referred elective admissions get cancelled from the ICU because of ICU bed availability. So, trying to figure out, so the outcomes in ICU are obviously quite concerning. Trying to figure out which of those patients who are going to be most likely to benefit from ICU is very difficult. And, there's a whole lot of statements there about trying to balance quality of life versus acceptable outcome, and just because we can do a procedure doesn't mean we should, are very easy to say, but it's very difficult to actually practically apply that to individual patients. I think from a practical sense, I think it's important for people to have a very realistic discussion with their family and the patients prior to initiation of therapy. And I know that that's a more difficult discussion in an acute emergent setting, but that needs to be quite well made to the family, that coming to ICU after an operation or from the development of a complication may prevent the immediate deterioration, but the actual outcome is quite concerning. And obviously, realistic expectations of patients and family needs to be set fairly early on in the care, and ideally that's before operative intervention or deterioration has occurred. And I know, there's a lot of different hospitals that develop, but I would suggest that, trying to develop a plan with patients about risks of deterioration before things occur is probably best. Certainly, I think adoption of palliative procedures, palliative surgical procedures, and you could argue that the neck of femur is a palliative procedure as well as a whole lot of other palliative procedures, are probably appropriate to provide perioperative support for a short period of time. But I think there needs to be a recognition that once complications occur due to all those significantly deteriorated ability to mount a physiological response, then if a complication occurs, then there needs to be a ceiling of care that should be developed sooner rather than later, rather than running the risk of putting patients through a whole lot of invasive procedures with very little outcome. That's all I had to say.
Thanks very much. A lot of parallels with neurosurgery, vascular, we've heard earlier on today. How do we identify these patients preoperatively, particularly in when they are admitted from the emergency department, often in extremis, and you've got to make a decision fairly quickly?
Yeah, there's obviously some decisions are easier than others. I think part of that is going to be patient and family wishes, but part of that discussion is also about, rather than just do you want an operation, do you want everything done, it's also about going through in detail what everything done actually means. And I think we see it all the time of the family wants everything done. Yeah, that's great. They want everything appropriate done, but do they actually mean everything that needs to be done is inappropriate? And I think trying to discuss appropriate cares is more appropriate than just asking what do you want done. And I think the implications of having a procedure doesn't always mean that you have to go to ICU. I think that if there's a patient who is of much physiological concern and has an indication for an operation, I think a reasonably sensitive conversation with the family can be, we can provide this operation for symptom control or whatever outcome you want, but this is either going to go really well and we'll go to the ward and continue treatment, or a substantial problem is going to occur, at which point we're not going to provide further amounts of care. I don't have the answers of who that kind of comes. I don't think anyone does. There is, trying to apply population statistics to individuals is very, very difficult. I think it's got to be a case-by-case basis, but I think there needs to be realistic expectations of the family before intervention occurs, if possible.
At the moment, we have a potential scenario is an emergency resident liaising with a surgical registrar who liaises with an anaesthetic registrar, and then the intensivist gets notified once the patient's in theatre and things aren't going according to plan. Is there a better way?
Yep, that's what we see all the time as well. And the answer is almost always we'll provide perioperative support and then negotiate with the family about, realistic outcomes afterwards. I mean, I think these decisions shouldn't be made by residents or registrars. These decisions should be made by consultants, and probably surgical consultants with anaesthetics and ICU for a genuine multidisciplinary approach about what we expect to be able to achieve. And after hours is always very difficult, but I think when achievable, this should be made by the most senior people, particularly the senior surgeon and intensive care support if that's what's being provided.
Sorry, Russell Bourne again. When I graduated in the early 80s, we pretty much knew as an intern then that if someone was out at 65, there was no way in the world that they get in your ICU. And you talk now about assessing patients and all this kind of stuff. Isn't there a point where you have to actually draw a line in the sand and say, this is not appropriate, this is where we think we should be, and then discuss it up and down before the patient turns up? Because at the moment it does seem to be that if there's a problem, you put them in and you think about it. Is it not time where you actually have to say, stop, this is where we think it should be, and then you have a discussion among the people framing all the care? Is there any caveats of why you wouldn't or would not take that patient, say, 85 now?
Absolutely, but you're ageist. I think that would be absolutely appropriate.
It's chronic, you just talk about physiological age.
No, I mean,
that's why I'm talking about, go up and down.
I completely agree with you. The problem is that there is no appetite in the community to ration resources. We just don't have, it's not just an age problem with also, for us in intensive care, it's also a comorbidity person. We have someone in the ICU right now who has a GCS of 3 for 3 weeks after multiple cerebral infarcts, who's 77 years old, who has anuric renal failure after a urosepsis. Now, the family refused to accept that that is life-ending, and so we have to go down a QCAP process to try to relieve them from their decision-making ability. Now, in Queensland, unfortunately, as opposed to other states, we don't have an ability to withhold or withdraw life-sustaining therapy. Now, that's a very confusing decision because what's that, or statement, because what does that actually mean? But there is a significant problem between what clinically is optimal medical care and what families and the communities accept. So rationing, although it happens in a lot of other countries, doesn't happen in the US, and we're going very much down that pathway. I think if we were to say, if you're 86, you don't get into ICU, I'm sorry, there would be a great deal of up in arms in the community. I don't think there's a community appetite, and there's certainly no political appetite for us to provide an upper limit. If you talk to the people who were here in ICU 30 years ago, they would agree with you is that you'd have to be, if there was an age limit, that would be stuff. But I think that at the moment, although we're all very frustrated with the creep in ages and the increase in admissions.
But isn't this kind of why we should be having this type of meeting rather than the QASM? Shouldn't we have got the ability to try and identify some of this information and start driving it down the path with the health funds and having the discussions? And you're not going to have this discussion until you actually throw it up there. Because the alternative is you say, okay, unfortunately, you've got the 85-year-old who's going to soak up all these ICU services, and what does that then impact on the rest of the community? So you can say, this person, it sounds awful that we're down to the sort of dollars and cents, but you've now spent $120,000 on this 85-year-old who was never going to survive. So 6 other people are going to miss out on some other form of care.
Absolutely agree with you.
And if we just keep letting it drift, it's just going to keep going.
I absolutely agree with you.
Some of them must have just stand up and make a statement and be, the tomatoes thrown at. That's what we're going. So who's that?
QASM can't do that, but I can tell you this. For the last few years, we've got a clinical ethics committee at PA. There's an intensivist on it, there's an anaesthetist on it, there's physicians on it, there's peri-op nurses on it, there's maybe some people here are actually on it. But, we've been presented complex cases by surgeons who say, I don't know what to do. I give you a fairly simple one. Chronic self-harm, mid-20s, frozen abdomen, fistula. Okay, so the general surgeons in the room are all thinking, heaven help me. And that's the only place you'll get help from. But what do you do then? You know, if she's going to have a laparotomy today to try and deal with that bowel obstruction, she could die. She'll probably have to go to intensive care. The anaesthetist is going to hate you forever. You know? And here's a poor surgeon who's got a whole 150% of heart in trying to get the best for this patient. And the mother says, I want you to do everything you can. So that's an impossible task. I mean, Phil might have you had that one?
Yes, yes, you do. We have a lot of cross swallowers from prisons nearby, so we think that's a...
Yeah, but is it almost at the point where we're getting distracted, but it's almost what I think this meeting should be almost about, is that are there ways that we have to try and drive it better?
Yeah. The QASM data can drive it, but not QASM individual cases. But to tell you the truth, but all the surgeons will be involved in that clinical ethics process. And again, this is a corporate decision-making process. Sometimes it's gone once to QCAT, Queensland Civil and Administrative Tribunal, where the law takes over. Does the person have capacity? Does the parent have capacity? Where does the capacity lie in this decision-making process? And I think I'd commit to you the potential for a clinical ethics committee. And again, Julian can't make it himself, Jason can't make it himself, I can't make it myself. It really needs to be a community that's doing this sort of stuff. And QASM data can't do it. All QASM data can do is say that, you know, if you're over 85, the graph says that intensive care is not really going to change the situation.
But that's almost part of the discussion.
Absolutely, yeah.
At 85,
yeah.
I'm sorry, but, you know, putting you into ICU is not going to help, so you have to try.
And we can put the data there.
We can look after you there and see if there's navigation data. Putting you into ICU is...
Exactly.
Don't we need to step down a position where we call it high care, stroke palliation care? Is it always all or none? Because running an ICU costs an absolute fortune. I mean, it's at least 2.5 times the cost of having a patient in a ward, and that's expensive enough. So somewhere along the line we have to have some kind of step down position. And the other question is it not time for us to now involve politicians? Maybe the law needs to be changed.
Absolutely. So I think in terms of step down, you know, I think these patients come to ICU because almost certainly they need some type of respiratory support, and you know, that's ventilation by and large most of the time. And you can't do that, unfortunately, anywhere other than ICU. If you don't ventilate them, then they're starting a palliative process. But I mean, the second part is we definitely need to engage politicians about this. The QCAT patient who I've spoken about, I mean, we would do 3 or 4 similar type of QCAT referrals every year for varying degrees of you know, families who are completely resistant to any type of acceptable, you know, or reasonable outcome to kind of discussions. And I think, you know, rationing of healthcare, which is what we're talking about, whether it's in the 80-year-old or whether in the 20-year-old who's doing this to themselves continuously and actually has no functional ability, or the cerebral palsy patient who's non-verbal, who's got contractures, who's got bed sores and pneumonia, who comes in 3 times a year. I mean, that's what we're talking about, is rationing those services, all of which I think most reasonable people would expect that would be appropriate, not to provide everything for, but provide a ceiling of care. I mean, we have no ability to do that without the consent of the family or the patient in Queensland. And you know, we are, from an ICU community, trying to engage. I know that our regional, I mean, this is not just Royal Brisbane, this is a Queensland-wide problem. Our state network has spoken to the Attorney General about trying to change some of that legislation, at least so that you've got an ability as a doctor to say, this is futile / inappropriate care and I'm not going to provide it. Because at the moment, we don't. It's never been challenged in court, but certainly the legislation, the last amendment to the legislation is such that we can't say that.
So in fact, I see on a monthly basis we have brain tumours that end up getting cancelled because there's no ICU beds. And those patients are really worthy candidates because there's a good chance that they're going to they're going to survive and benefit from the ICU visit. So their surgery has been postponed. So when we look at it in a global fashion, in fact, some patients are being disadvantaged because others are being, dare I say it, selfish or inappropriately blocking ICU beds.
Absolutely.
Some kind of step. I mean, this is the rate limiting step for elective, serious category 1 urgent patients is ICU inaccessibility, and it frustrates every surgeon too.
Look, it frustrates us.
Solutions, but I do think that we need to start stressing the politicians a bit.
Look, it frustrates us as well. I mean, I think we can provide beds. I mean, that's what we're there for, is to provide kind of a service that, for the most, who are going to be able to benefit from it. I think that the limitations is certainly real.
We need to wrap this conversation up. It's really complex.
Part of the problem that we're not prepared to make hard clinical decisions anymore. I mean, I would challenge you that your patient, if you said, I'm not going to dialyse this patient would die. You know, the relatives can't make you dialyse that patient. The same thing is, if somebody comes in...
How do you respond to that?
So
you can't...
Look, I think, futile care is very difficult to define. That's been moved away from, definition of futility, because it's impossible. So if you're saying to a family member, I'm not going to dialyse this patient because it's futile, that's not true. Because if you dialyse that patient, they're not going to die of renal failure. Is it inappropriate in the context of that patient's care? Absolutely. But the renal physicians, certainly at this hospital, never refuse dialysis, ever, if a patient says that.
But
because
that's what I'm saying, aren't we advocating clinical care here? Aren't we refusing to make the hard decisions that are appropriate to patient care? And look, I mean, I could argue that we can keep on this sort of thing and say, okay, we get somebody in who's got ventilatory incapacity, we can put them on back support and we can keep them alive, and then we can get an artificial heart, and we can spend huge amounts of money and keep people alive almost indefinitely if we have the resources and if we have the wealth. We don't. And we don't have some of those things, so we don't offer them. So I think at a certain point in time, we actually have to make the hard decisions and say, this is not appropriate care for this patient.
I think
Can we throw this back to you to say, this is not a black and white decision, this is, shades of grey, and I think we're all feeling the burden of taking that responsibility all by ourselves, and perhaps doing it within a, for want of a better term, a multidisciplinary environment, and early communication with the family, and then involve the administrative channels, the QCATs, etc.
Absolutely.
After that.
The last thing I guess I'd say is that, I think we can do that. In most families, if you can get a consensus with all the clinicians involved and say to a family, this is inappropriate, most families and patients are accepting of that.
I mean, should we be having a situation where we have committees in hospital that something goes and says, we won't progress, this will not be offered to this patient because it's inappropriate for this patient's care?
Absolutely, and I think you could try that, and it sounds like the PA does that, but I think from a legal sense, certainly at the hospital I work in, is no administration is willing to support that process at the exclusion of a patient list. So if a family member says, do not withdraw that therapy, the hospital administration...
I'm not talking about withdrawing therapy, I'm talking about non-instituting.
Yeah, so that's considered the same thing in the law. Withholding, withdrawing, considered the same thing. So if you don't institute it, it's still withholding the therapy. It's considered the same component, withdrawing, withholding. I mean, I agree with you completely. I agree with, completely this should be a clinical, best medical approach that we can provide, and that should be consensus-driven. And most family members will, and patients will take that on board, but there are some that don't. And I think, there is certainly a slide, with us being able to do more and more older things and, more and more complex patients at the expense of patients who are, more appropriate, who would benefit most from it. I mean, I don't think it's an easy solution, as you've said, and I think that we all do feel it.
Taking comfort in the fact that we can consult our colleagues, be it within our specialty or outside our specialty, where they have their various different areas of expertise, to reaffirm to us that this is probably the best way to go, and so that the team decision then liaises with the family. I don't know. We're not going to get an answer for this today. today.
No.
I acknowledge that there's a question that there's people watching on a webinar, and there is a question there which is kind of flipped it around 180 degrees.
Right.
Can we, if we were to develop these review committees, some people would almost call them death boards. So, just to paraphrase the webinar question, could you actually deny someone care in an intensive care facility who's actually good enough, but they don't meet the requirement based on a numerical score? It's a bit of a philosophical question.
Yeah, so I mean, no, you probably couldn't. I mean, part of providing care is kind of best medical care that I guess you could provide. And I think that's the problem with providing population statistics to an individual is you can't say that individual has a 5% chance of dying. You can say that anyone, in that cohort, 5% of people died. And trying to apply, even our mortality predictors in ICU, we've got lots of different scores for mortality predictions, is not always 100% sensitive. There are some people who don't have that. So I think, any scoring system, there should be some reasonable rules on it, and the scoring system has to be, used in that context. But yes, certainly everyone can make bad decisions. So there might be people who benefit if you just have a blanket rule who won't actually get in if you use it that way.
All right. We're going to wrap it up.
Okay.
Jason's
Thank
been
you very
sweating
much.
up here. Well done.